Welcome, everyone. It is my pleasure to welcome you to the Tardive Dyskinesia 360 presentation on achieving and maintaining improved quality of life in patients with tardive dyskinesia. Very much looking forward to being with you. As you've already heard, my name is Rakesh Jain, and I'm a clinical professor in the Department of Psychiatry at Texas Tech Health Sciences Center, School of Medicine, Permian Basin in Midland, Texas. Here are my disclosures available for your full review, along with some disclosures regarding the presentation. I am very careful to disclose off-label information when that occurs, and also this content was independently reviewed for balance. And the video clips of patients were obtained with their permission. Our learning objectives. Number one, we will outline the consequences of untreated tardive dyskinesia and the impact that has on quality of life in such patients. We will also describe the aims in some detail. And then finally, we shall look at how do we incorporate the currently available data on the short and long term, but particularly the long-term efficacy and safety of the VMAT2 inhibitors for the treatment of TD in clinical practice. Definitions. I know we have covered it before, but if you will permit me to do so again rather quickly, tardive dyskinesia, of course, is a disorder that is involuntary, abnormal excess movements that emerges after long-term use of antipsychotic drugs. It can affect a number of body parts. We will look at that in just a minute or two. But please note, it is three kinds of movements: choreiform, which are the rapid, jerky, non-repetitive movements; athetoid movements, which are much more the dance-like sinuous movements; and then finally the rhythmic movements. That are the three abnormal excessive movements, dyskinetic movements, that are part of this disorder. Who can explain this condition better than patients can? No one. Therefore, we have several patients who have been very kind to lend us their perspectives on living with tardive dyskinesia.
The tongue movements are things that are unusual, that people kind of stare at and wonder what's going on with you or why that's happening, or it embarrasses them and they withdraw or are judgmental.
I have difficulty swallowing. I cough a lot. I choke up a lot, even with water.
Living with it is not easy, especially when you don't understand what's going on and what's happening. Because it wasn't understood in the whole deal. It was hard for my family to understand what was happening to me and what was going on and why is Dad nuts.
I have to schedule an appointment.
Because I have to schedule his appointments.
I can't answer the phone.
You can't answer the phone. The way it's kind of impacted our marriage, it does have some negative impacts. It's kind of how I see my husband. So he used to be like my protector and my best friend, and I still see him that way, but it's taken some work to see him that way still, because when it first happened, I felt like I had to take care of him, and I felt when people were not nice to him, I had to defend him, and it went from being like this my equal to almost being like my child. And once I realized that wasn't right, it's not like just because someone can't speak doesn't mean that they're not mentally there. And so now it's just trying to get that point across to everybody that we know. And people have stopped talking to us. We have lost a lot of friends, and that's fine. It's just been really hard. So it's taken a lot of work and therapy for both of us to kind of be okay with accept what we have.
I bet that was as difficult for you to hear now as it was for me when I sat across from them, interviewing them. And to me, the messages coming across from the patients are not that this is a movement disorder only, that there are major impairments. There were impairments in socialization, physical mobility, psychological impact. In fact, the last couple you met, did you notice the gentleman was carrying a cane? Not able to walk very much because of his tardive dyskinesia. In fact, he has trouble even swallowing liquids, water. He has to be very careful sipping it. His wife has to act as his translator. And this man was a soldier. He came back from Iraq and he had a refractory mood anxiety disorder where he received very appropriate treatment with medications, including an atypical antipsychotic. And this is what happened. So I hope we never forget that tardive dyskinesia is simply not just a movement disorder. It's a movement disorder with significant negative impact on quality of life and functioning. And it's common, as I'm showing it to you here on the slide. It is less common with second generation atypicals. The only problem is we are using so many more second generation antipsychotic medications that both have become real challenges. So let's remember, if we're looking for a safe harbor with antipsychotic medications, we simply don't have them. And the clinical course often is a worsening clinical course. We don't tend to see this immediately. As you know, typically it's after 3 months, but sometimes it can be after 3 years. Sometimes it can be after 30 years and everything in the middle. The challenge is in majority of patients, just changing the antipsychotic medication is not going to solve their problems at all. Therefore, when tardive dyskinesia arrives, as early as possible, the correct diagnosis and treatment are actually quite important. There are certain known risk factors, but just being on an antipsychotic medication is a risk factor. Age, schizophrenia, dosage, comorbid mood disorders, history of Parkinsonism, tremors. When those occur, the risk does go up. There's no question about it. But it does appear the single biggest risk factor, or amongst the top, is being on an anticholinergic medication. As I've said before, and the patients said it far more eloquently than I ever could, great impairment comes from this disorder. But what does the data show us? And this is what the data tells us. The tardive dyskinesia negatively impacts life no matter what the underlying diagnosis was: schizophrenia, major depressive disorder, or bipolar disorder. Here's a study from just very recently that shows tardive dyskinesia patients compared to those who don't have tardive dyskinesia, even when they have schizophrenia or bipolar disorder or unipolar disorder. Tardive dyskinesia just adds to the troubles of such patients. And by the way, employers, without even meaning to necessarily, will perhaps discriminate against or have a negative opinion about someone who is equal in every other way, but may have tardive dyskinesia. This particular study of a very large group of individuals showed that when we see people with tardive dyskinesia, whether it's implicit or explicit, there are significantly biases. So what underneath the movements, what underneath all of that is the neurobiology of this condition? This is what we know. Multiple factors impact tardive dyskinesia. We do know dopamine is involved. We also know it does appear that the postsynaptic D2 receptor, after chronic exposure to antipsychotics, may actually have increase in the number and density and then becomes hypersensitive. Therefore, even normal amounts of dopamine that are arriving actually set off a cascade of hyperkinetic movement disorders, which we call tardive dyskinesia. In other words, tardive dyskinesia is caused by the treatment we give the patient for other psychiatric conditions. So how do we treat it? And here's the birth of a new mechanism of action. If we aren't yet familiar with it, we should become familiar with it. In 2017, we had two medications who worked through this mechanism of action, VMAT2 inhibition. What is VMAT, by the way? Vesicular monoamine transporter. And the reason why I'm putting 2 behind it is because these medications are selective for it. What do they do actually? And this is what they do. They deplete the dopamine from the presynaptic, not the postsynaptic, the presynaptic neuron. But they tend to do so, obviously, in areas that are dense with VMAT2. One of those areas is the dorsal stratum. If you're looking at my head, not the front part of my head, but the back part of my head, where I control voluntary movement. If you're able to reduce dopamine, which is the major offender in terms of setting off these dyskinetic movements, then of course it makes sense this localized dopamine depletion could actually improve these abnormal movements. And as I'll show you later, the evidence is actually quite good supporting that VMAT2s, these VMAT2 inhibitors, are indeed the birth of a new mechanism of action. Identifying and assessing for tardive dyskinesia is so important. Nearly every patient I interviewed in the series you just saw a few minutes ago reported to me not just several months delay in diagnosis, quite often several years, and in some cases, a couple of decades. It wasn't that they didn't receive the right diagnosis or that they didn't receive a diagnosis. They did receive a diagnosis when they presented with these movement difficulties, but often they were incorrectly diagnosed as suffering from, yep, you got it, EPS, or Parkinsonian symptoms, which they manifestly don't have. They got the wrong treatment. They also had a significant delay in diagnosis. What is the best way to fix it? Awareness and the use of a scale such as the AIMS. And the AIMS examines all 7 body regions of importance to us. Muscles of facial expression, muscles of facial expression, lips and perioral region, tongue, jaw. That's 4 areas above the neck. Upper extremities, lower extremities, and trunk, which includes the neck. This is pretty much 7 body areas that we assess using a scale such as the AIMS. AIMS has rapidly become, for all the right reasons, the gold standard for 2 things. That's why it's such a great scale. Number 1, for the accurate identification of tardive dyskinesia. But the other is for the measurement of tardive dyskinesia once you have a patient with a diagnosed condition. So when you treat them, you can watch the progression, hopefully in the right direction. What is a positive AIMS? If you have a score of 2 or more in 2 or more body regions, so 2 or more in 2, tardive dyskinesia, or a 3 in a single one of those 7 body regions. May I draw your attention away from the first 7 items of the AIMS? Let's look at items 8, 9, and 10. Those are not movements as much as an attempt to better understand the insight and the impact this disorder has had on the patient, which I think is incredibly important. It's time to put psychiatry in the category of both an abnormal movement disorder and the category of impairment and bring them together. It's not just abnormal movements. It's more than that. There's a price tag to it. That's why in today's presentation, we're focusing so much on quality of life as well as functioning. So the AIMS, it's actually very straightforward. In a minute, I will give you lots of resources on how you also can, if you're in need of it, burnish your skill set in how to do the AIMS. It's always done in a chair. It's always in a chair like I'm in now, where there's no armrests. Ask if there's anything in the mouth. If they have teeth or dentures, hey, watch out. I've been trapped by that before. A patient may be there because at that particular visit, they're not wearing their dentures. And then they have intentionless movements, and we could get confused. But look at item number 4. This is so crucial. We assume that the only way to do the aims is for us to do everything, but there actually are items in the aims on how to conduct it that ask us to interact with the patient and ask them if they noticed any movements, because we don't want to miss things that didn't happen in the brief time we spend with our patients. So here you go. I recorded a video. It's only 8 minutes long. Only 8 minutes long. I would highly encourage you to look at it. The link is provided to you right here on this slide. I really encourage you to spend about 8 minutes, either by yourself or your treatment team or with your students, and looking at a gold standard way to do the examination. And by doing so, if you have perhaps created a different pattern of doing it, it may not be the best way to do it because the gold standard way is important. So when I refer you a patient or you refer me a patient and I say they have a score of 7, then we are speaking the same language. Or if I say it's 0, you can be very assured I'm doing the examination the same way that you are. Do check it out. It's become so popular, it's now used as a 8-minute teaching course in many residency programs and nurse practitioner training programs. Telepsychiatry does provide some significant challenges, it does, but they're solvable. So what are the challenges? It's hard to do the full aims. I mean, how am I going to watch you walk, for example? It is, as I said, a pretty difficult way to do it. And there are no guidelines right now. How do you modify the aims? There are no guidelines. But I would say 3 things. Number 1, a partial aims is still so much better than no aims. So please don't abdicate our responsibilities to address it. Number 2, having a family member or support system really helps. And by the way, if you're looking at me right now, just look at me if you will, please. Muscles of facial expression, you can see. Perioral region, lips, you can see. Tongue, you just have to ask me to open my mouth. Jaw, you can see. You can see my neck, and you're seeing my hands. You know what? You just completed 6 out of the 7 body regions. So, of course, it would be better to be able to see me walk and to have me stand, sit, for example, watch the trunk, watch my feet, watch my toes. But even in the absence of a perfect aims, telepsychiatry is not as big a barrier as we sometimes think. But there are diagnostic barriers. And those barriers are more, if you will, in our awareness and knowledge base, not in reality. Let me walk you through those really quickly. But before we can go there, we do need to know what are some of our terms. So EPS is a very bad term in many ways, because it's nothing but a collection of many disorders: akathisia, bradykinesia, dyskinesia, Parkinsonian symptoms, tremor. Those are all EPS. Do they have the same presentation and the same treatment? Of course not. Then why do we lump them together? It's a bad habit. It's better to divide them. And how do you divide them? I've got the information right here. I won't go through it in detail because you have full access to it. Just remember, there is such a thing as drug-induced Parkinsonism, tardive Parkinsonism, and obviously Parkinson's disease. I am granting you that. But if we can remember, drug-induced or whatever kind of Parkinson's or Parkinsonism is a hypokinetic disorder. Tardive dyskinesia is a hyperkinetic disorder. It'll help you. I hope you will come back and revisit this slide for more in-depth information. Now, how do we manage it? That is so crucial that we talk about. So the treatment paradigms are actually pretty clean cut. And the treatment paradigms are clean cut now. They were not before 2017. Now, Level A evidence goes to the new generation VMAT2 inhibitors, and we have two, Deutetrabenazine and valbenazine. If for some reason that's not appropriate, then we can turn to level B, clonazepam or ginkgo biloba. If for some reason that's not appropriate, we have amantadine as level C, and also at level C, we have a surgical treatment, deep brain stimulation. What about the Canadian guidelines? Those also came out just very recently. Guess what? Our Canadian friends agree with us. They also think VMAT2 inhibitors have the single best level of evidence, though in appropriate situations, we will not ignore and should not ignore amantadine, benzodiazepines, and deep brain stimulation. It's nice to know both countries with independent experts looking at data independent of each other are also coming to the same conclusions. Watch out for benztropine, cogentin. Do watch out. There's something about it that does seem to increase the risk of tardive dyskinesia. Not at all suggesting they're inappropriate situations. What I am suggesting, in fact, more than suggesting, I really wanted to caution you, is benztropine use chronically in situations where it is not clearly necessary comes with a lot of consequences. One of them appears to be a strong association with tardive dyskinesia's ultimate development. So as we look at some of the new medications, remember, we are talking about the birth of a brand new mechanism of action. So if your professional training was completed before 2017 and you did not receive much education about it in your training, like me, I finished back in 1993. Wasn't that I was sleeping in my lectures or seminars. We just didn't know at that time. So these two VMAT2s that we will be discussing work presynaptically. Antipsychotics tend to work postsynaptically. Therefore, we are allowed to use these medications concurrently if so necessary. Remember I said there are two medications, deutetrabenazine and valbenazine. There are pharmacokinetic and pharmacodynamic differences between them. Thank God. What am I going to do with medications that look exactly alike, right? They are different in that regard, but what does not appear to be different is the following. At therapeutic doses, the net occupancy of the VMAT2 inhibitors by the active metabolites of both compounds actually is comparable. Therefore, the question, important one, which is better, is not answerable. What is answerable is the following. There are differences pharmacokinetically, pharmacodynamically, and the good news appears to be if one for some odd reason is a challenge for the patient, we definitely can try the other. Let's now turn our attention to deutetrabenazine. Deuterium, did you notice DEU? It's a naturally occurring, stable, non-radioactive, non-toxic isotope of hydrogen. What they did extremely cleverly, they took out all 6 atoms of hydrogen from tetrabenazine and replaced them with deuterium. Reason being, deuterium forms very strong bonds with carbon, which makes it much more difficult to break down. So the active metabolites hang out for a longer period of time. That is thought to do the following. It reduces the frequency of doses required. Now we can go to BID and check this out. The half-life is prolonged. It's actually doubled. And Cmax, which is the highest concentration achieved, is also changed for the better. So deutetrabenazine is a significant modification on the parent compound. What about valbenazine? They took a different route. What they did, let me show it to you. What they did is they found what may be the most active metabolite of tetrabenazine, as you can see in the yellow box in sort of in the middle. And what they did is they attached it to an amino acid called valine, and that became valbenazine. So when a human being takes valbenazine, what they're receiving is certainly valbenazine, which has some activity, not too much, but some. But when it's broken down into this active metabolite, then that has the maximum VMAT2 inhibitor activity. Clever, huh? Both of them are, in my opinion, kind of space agey, significant modifications from a pharmacokinetic, pharmacodynamic perspective for the patient's betterment. And valbenazine, therefore, is given once a day. What about the evidence? What does the recent data tell us about these VMAT2 inhibitors for the treatment of tardive dyskinesia? Why don't we focus on deutetrabenazine first? What shall we look at? We will look at the decreases in the scores of the AIMS. And as you can see, there's placebo, followed by 12 milligrams of deutetrabenazine, 24 and 36. 12, not particularly impressive, but 24 and 36, clearly numerically and statistically significant. Please remember there are multiple doses to this medication. Only 3 are shown here in this study, but there are a grand total of 7 therapeutic doses, all the way from 12 milligrams in 6 milligram increments, all the way up to 48 milligrams. So 7 different therapeutic doses. But what about side effects? What we saw, headaches, 5% on deutetrabenazine, 8 on placebo, somnolence 4 and 7, diarrhea 4, nasopharyngitis 4.2, and fatigue 4 and 5%. Looks very favorable, does it not? It does, but it does not mean we can just abdicate our responsibilities to monitor our patients, adjust the medications, or whatever else is necessary. I'll offer you a couple of practical tips in just a couple of minutes. What about valbenazine? Connect 3 study. In this particular study, also they looked at reduction in AIMS. Makes sense. You have placebo, you have the 2 approved doses of valbenazine. It has 2 approved doses, 40 and 80, and both are clearly effective. Which is the better dose? Depends on the patient, obviously. Majority of patients with moderate symptoms do tend to be on 80, but 40 is a real dose and we can use it. It's actually on label. Both are effective. It just appears that 80 has greater effect size. And what about side effects? Again, the tolerability is actually quite good. Somnolence, as you can see, about 10% compared to 4% on placebo. Anticholinergic effects, 5.4 to 4.9. Balance/fall, 4.1 to 2.2. Headaches, 3.4 to 2.7%. And akathisia, 2.7 versus 0.5. Here too, the exact same rules apply, which is monitor carefully when they're starting out, watchfulness, dose adjustment, and whatever other changes are necessary to ensure patient safety and efficacy. 2 new generation VMAT2 inhibitors. Psychiatry and our patients did receive a big gift in 2017 when both these medications were approved by the FDA then. Now, those were short-term studies. You perhaps saw that. I'm sure you didn't miss it. What is the long-term data that we have? So let's look at deutetrabenazine, and it's kind of long-term, 2 years. We're moving on towards 2 years. And what are we seeing here? Well, not only are we seeing a persistence of effect, continuation of the benefit. If anything, if the patient continues on it, we're seeing more and more and more effectiveness with the passage of time. Now, if they stop the medication, it does seem to come back, but no emergence of new safety signals emerged. And if you look at CGI, which is a very good way to look at clinical global impression, you can see numbers as high as 70s and 80s in terms of much improved, very much improved. These are pretty unusual numbers. Psychiatry is not used to seeing patients have this number of patients having much or very much improvement. Makes me very happy. What about valbenazine? It makes me equally happy. They also have long-term data. And what we're seeing is, not just a persistence of effect, but the patient continues on the medication, it stays low and gets lower. If they stop it, in the majority of these chronically ill patients, the symptoms will return. No rebound, but they do return. Also, no new safety signals emerge. And again, if you look at CGI, we're still looking at numbers in the 70s, 80s, heck, even 90s in terms of patients reporting much better or very much better. Makes me happy. Makes me happy. This is such a problematic condition for our patients and their family members, as you heard the wife testify. I have no doubt you did not miss the tears in her eyes that she was fighting to hold back when she talked about what this has done to her personal life, their married life, and their social life. This is how effective treatment can be. This lady on the left, who I got to meet, this is her. She'd been off a VMAT2 inhibitor for a few days. This is where she was. We invited her back in just 24 hours, just to see. She went back on her previous medication. 24 hours later, you can see she's nowhere near where she needs to be. But it's obvious that the onset of action for this patient is actually pretty rapid with her VMAT2 therapy. Okay, what are some of the potential challenges? How do we address them? Sleepiness and sedation can occur with both medications. And I'm offering you literally a menu of choices, and they're all great options for you to consider with both medications. Dose reduction, nighttime dosing, and a few off-label things we can do. So on valbenazine, it's once a day. You already tried it in the evening, patient is still sleepy. I'm very comfortable saying every other day or so until we get the sedation to pass away, hopefully. Same thing with deutetrabenazine. I might tell the patient, skip the morning doses temporarily. It is off-label, but we just need to get you through this so that we have long-term benefits, which apparently has a 70-80% chance of getting you to very much better or much better. It's worth doing these small things to help the patient out. Same thing with akathisia EPS. Control the dose, control the escalation regimen, and adjust the dosing. And here, if you need something else, you need propranolol, that's okay. But dose control, time control, and the passage of time are very valuable adjuncts as we're trying to stare down the risk of too abrupt a discontinuation of the medication. Lack of insight is quite common with our patients. We do have to confront that. A good way to do that, particularly in our patients with schizophrenia, is to not talk so much about the abnormal movements with them. They don't have that much insight, but to talk more about the impairments. So what do you want to get better? Oh, I want to be able to cook for myself again, or get dressed or not fall. Focus more on that. That has a higher yield, in my opinion, experience, than just talking about the symptoms. 3 things, let's never forget. With these VMAT2, these new generation VMAT2 therapies, there is no need to discontinue, reduce, or change their underlying medication, antipsychotic or antidepressant, and both are effective no matter what the condition is, be it bipolar disorder or schizophrenia or whatever. If it's tardive dyskinesia, it's tardive dyskinesia. I'm so pleased to report to you that there are now newer guidelines. This one I was involved with. These are the modified Delphi guidelines in tardive dyskinesia. They came out, well, in 2020, as fresh as it gets, does it not? A few of us who are thought to be experts in the field of tardive dyskinesia came together. We discussed, we agreed, we disagreed. There were lots of agreements though, and we're going to present to you some of the agreements here. We then also ran it by lots of other people. We wanted to make sure we were not making any mistakes. So we involved other experts too, and there is consensus. And there was quite a bit of experience. The average experience was about 29 years. This is what we came up with, folks. I have no doubt you will agree with us. First things first, screening. You might say, let's talk about medications. That is so much cooler. It is interesting and important and valuable. But screening is it's a significantly unmet need in American psychiatry and American primary care, where we do use a lot of antipsychotics. We often say it's low dose, it's for mood disorders, it's not a risk. And that is not true. It's manifestly not true. Exposure to a D2 drug is the risk. So we should use something like the AIMS. We should definitely, obviously, interact with the patient and alert them if they themselves see a problem to come back to us and talk to us about it. Treatment approaches, we don't decide by ourselves. Let's involve the patients and caregivers. If you can, adjust the antipsychotic regimen. Sometimes you can, and that'll help the patient. But if you can, that's okay. There's no reason to harm and help the patient. It's okay to help and help the patient. And of course, the treatment of tardive dyskinesia, assuming there are no other variables, we start from the top, right? We go with grade A evidence, and that goes to the 2 VMAT2 inhibitors that we discussed just a little bit ago. And the treatment approaches measure, measure, measure. Because once we treat, we got to know what we're treating and is it getting better or not. We will have to also treat the underlying psychiatric disorder. We should. And needless to say, we shall focus. We need to focus. We're obligated to focus on quality of life and impairment. And if there's anything you can do with the anticholinergic medication, by all means do so. And then as we keep going on, the VMAT2 inhibitor therapy becomes part of the integrated program. So the patient now says, I'm not so embarrassed to go out in public and go to the nearby grocery store. That's a major plus. But now the patient could be encouraged to do things that they had completely stopped because of tardive dyskinesia, perhaps dating, perhaps looking for a job. It's okay to tell them it's safer for you biopsychosocially to re-engage with life in a way that tardive dyskinesia could potentially have stopped you from doing so. And by the way, which VMAT2 inhibitor therapy to pick first? We don't know. What we do know is both are effective. We do know there are differences. Therefore, as I'm saying here, think about the tolerability, safety, efficacy, and ease of use. That particular quartet is unique to each patient. It's just like fingerprints on my fingers. It's so unique to me. So if I'm your patient with tardive dyskinesia, my tolerability, safety, efficacy, and ease of use issues are unique. So at least you got 2 options with some differences. You will be able to pick the right one. But if for some reason that did not work out as well as you and the patient were hoping for, switching to another VMAT2 inhibitor is perfectly reasonable approach to take. Can't tell you how excited I am to bring this to you. This is breaking news. In fact, quite recently, APA put out its 2021 guidelines. They put it out in 2020, but they are guidelines for 2021, and they're effective immediately for the treatment of schizophrenia, treatment of patients with that disorder. And tardive dyskinesia being so common, they took the bold step of addressing tardive dyskinesia headfirst, which I think is very commendable. May I bring to you some important news from the APA guidelines? First, that patients with moderate to severe or disabling tardive dyskinesia should be treated with a VMAT2 inhibitor. And the VMAT2 inhibitors they are recommending based on data are the 2 new VMAT2 inhibitors that also have FDA approval, Deutetrabenazine and valbenazine. We got that. Okay, but hold on. Mild should also be treated. Assuming that the mild tardive dyskinesia is creating impairment, has effects on psychosocial functioning, or the patient just is so bothered by it that it's impairing not just their functioning, but it could threaten their very adherence to their treatment, etc. So yes, we should think about mild, moderate, and severe tardive dyskinesia very much in the crosshairs of our intervention. And our intervention, according to APA, yeah, we match two inhibitors that are the two new ones. They went so far as to also offer a caution about anticholinergic medications. This is what they say. Anticholinergic medications do not improve and may even worsen tardive dyskinesia in addition to producing significant side effects. Come on now, psychiatry, we need to really listen. We've now been cautioned about this enough. Now it's time for us as a specialty to rethink what we have been doing and take appropriate steps. And if we can do other things like reduce the dose of antipsychotic medications and other things, that's fine, but the odds are quite high we won't have that option. In case you want to look at the entire guidelines for yourself, because they're so new, it's possible you haven't had a chance to do so. I'm providing you a link where the entire 300-some page guidelines are presented for our review. So, in conclusion, I will say the following, if you'll permit me. Screening. You're saying he's already said that twice. Yeah, I did. Can I say it the third time? When something is that important, let's just say it one more time. It's very important. But innovative alterations of tetrabenazine, like the two I talked about, deutetrabenazine and valbenazine, are very useful medications. Let's not forget about them. I was able to show you short-term. I was able to show you long-term. I was able to show you durability of effect. I was able to show you quite long-term clinical global impression data. We looked at side effects in some detail. We looked at how to solve some of the more common side effects. All tell us we are on the right track, and improving functionality is an equal, co-equal goal of the treatment of tardive dyskinesia, besides just reducing the abnormal excess movements. I hope this was helpful to you. Thank you very much for your attention, and I'm ready for our Q&A. Thank you.